Unfortunately, I've got a lot more slides than I planned because I had revised them down, so I'll go through them quite quickly. And, well, ENT's role in sleep apnea diagnosis, the definition of the condition is upper airway obstruction. The nose is the true first part of the respiratory tract. We do share the airway with the chest physicians. Mike's done all the numbers and presentation about definitions, mild, moderate, and severe. And I suppose you as a group are really quite interested in the mild and moderate group where mandibular advancement devices are very good. I'm very supportive. And I think that historically, the way things were set up is that sleep apnea was a domain of the chest physician. But now, chest medicine and ENT work really well. Certainly in allergy, we've been doing joint clinics for 15, 20 years. It's not a new thing. And actually, when I started off with a chest physician who just happened to be the medical director, which was actually very helpful. He can clear all sorts of obstacles out of your way. So teamwork works well, and I think there's a huge role for MDTs, and certainly dentistry, maxillofacial surgery. You all have a role to play. This is a huge and exciting area to be in. It's more the serious side of medicine, but because it's the more serious side, you have to be a bit more careful. So aligning yourselves with a good clinical service, whether it's medical or surgical, is probably a good idea. Other features, loud snoring. We've all heard this, as Mike said. You know, it's funny if it's happening to somebody else. I've had various patients come to see me. If you don't sort him out, I'll kill him. There are different ones where they tell you that you can psychologically traumatize the dog. It sounds funny until you're in that relationship, you're sleeping next to that person, and your relationship is in tatters. You wake up tired in the morning, both of you didn't sleep well, and you go at it. If you're not in the same room in a relationship, that's a big step in your relationship, and sometimes it leads to divorce. Loss of interest in sex is always a very worrisome thing with men. If you're tired all the time, you tend to be depressed. In fact, I just anecdotal, I had a lady who works for me in my reception in my practice in Pilgrim, who's been treated for depression for 25 years. And she's been working with me for 7 until she kind of broke down and was off work. And then, you know, light bulb went on. So she's got sleep apnea. 48 hours later, she's absolutely fine after treating therapy, after 25 years. So sometimes something's so close to your face, you don't actually see it. So do think about it. And the associated diseases, hypertension, obesity, well, obesity is going to be the biggest thing that we're worried about, and there seems to be a pan-European, if not global, phenomenon. Hypertension, strokes, diabetes. A lot of the patients that come into my clinic have already been to cardiology. They're already in the diabetic clinic, but trying to convince cardiology and other endocrinology to work with you. You see, medicine works in silos, either your ENT, respiratory, general medicine. But now we're getting a stroke physician in our service, and hopefully you'll give us some sensible medical advice. This is a lovely graphic which, in a summary, just outlines all the impact of hypoxia to every part of the body. There's no cell in the human body that doesn't need oxygen. Just some are more sensitive to others. So you start thinking, well, stroke is pretty bad. Mood disturbance, that's very, very common. When you wake up grumpy, you're grumpy at work, you're tired all the time, you start picking arguments, your work productivity can drop by 30%. Over time, these people with severe sleep apnea, untreated, has about a 15% 12-year mortality, a 35% 12-year chance of having a major stroke or heart attack. So it's all serious stuff, and you don't want to just give a mad out to somebody and then have a legal issue later on down the line because you didn't actually work that patient up. You just gave them a therapy, and if you think about medicine is all about history, exam, investigations, then therapy. So if you're anxious or worried or concerned, work in partnership with a local service. This is one of the things that they always say, working group, Epworth is dead. It's out of date now. You want to move towards the stop bang questionnaire, which is developed by an American anesthesiologist. And it's quite easy. S, snoring, probably in a separate room as well. Could be heard in a different room. You're tired in the morning. You've got observed your partner's observed apneas. You got high blood pressure. That's what the P is for. Your BMI is above 35. your age is more than 50, your neck size is more than a 15 and a half, and your gender is male. So it's a quick, easy one for you guys to administer. If you're thinking about it, stop, bang, very easy to do. It's far more targeted. Epworth is actually a measure of sleepiness. It's not and it's very soft and woolly, but unfortunately, historically, it's always been used. So a lot of the papers quote on Epworth now, but as the working group recommended, we should move towards stop, bang, so that will come through in the next year or two in the literature. Standard sleep study. Mike's covered most of these things. It is an interesting field for you to get into, and the home diagnostics can be very, very elegant. This is a WatchPat, which is a tier 3 study, so it looks at sleep architecture as well as all your respiratory parameters. But you know, the buying price of these start at about 5,000, so it's not, you know, an occasional hobby. You've got to be doing enough of these to justify it for you. And this is what Mike was talking about. I don't know at what point these should overlap. But certainly, if most of my patients are men, if the wife, the daughter, the sister, the mother, the grandmother, or some sensible female in the family is identified, you need to go to the doctor, you probably will go. And it's some patients looking at things like Epworth, you say, well, do you feel tired? Well, if they felt like that all their lives, then they don't register it as I'm feeling tired. That's just the way I am. It's a relative term, and that's why Epworth doesn't work. But I think there's our understanding of where does bad snoring stop and upper airway resistance start, and then does that migrate into sleep apnea, where you desaturate. We tend to see younger males with upper airway resistance. So some of them come from the city because obviously they've got busy jobs, they have to function at work. Put them on CPAP, they do really well. Yes, multi-level problem. It's not just anatomy, it's not just a physiology, there's also neuromuscular elements there, and there's probably stuff we don't even know. Because actually, in the early 90s, there was a paper by a chap called Wright that trashed CPAP as a therapy and sleep apnea as a condition that you needed to treat. So the commissioners took it as an excuse not to fund it. So we're a good 10, 12 years behind States, Canada, Australia. And what you'll find is now we're starting to catch up a little bit. This is still in its infancy. There's still many things we don't know, and there's not one size fits all. So it's I think if you've got problems and they're complex, maybe if you get a lot of clever people together in a room, maybe you'll have a better outcome. So MDT working is something that we did push forward in the OSA working group. So actually from this April, it is a funded service to have more than one clinician from a different specialty in an MDT group in a sleep service. So that may be an opportunity for you guys to bond with your local team. If it's funded and somebody's paying for it, well, I don't see why you shouldn't get involved. Airflow dynamics. I think this is where, when I was a trainee surgeon, we used to use rhinometry and all that lead rubbish, doesn't work. This is more exciting. Airflow dynamics is where it's all going, and it's actually understanding airflow dynamics as the main principle for airway obstruction, and looking at laminar flow, turbulent flow, and the things that actually affect these things is very important for you. And actually, this is such a beautiful illustration because air arcs through the nose. That's the way it's supposed to flow. So anything that disturbs that will have adverse effect. And it's because, even the surgery, because this is the level of your inferior turbinates. People used to do a lot of turbinate surgery to shrink that down, but actually the airflow is not through the turbinates. It's not through the inferior turbinate. It's around the level of the middle turbinate. So one of my colleagues in America has some really good results by not doing traditional UPPs, but actually he's doing functional endoscopic sinus surgery, and he's not just looking at reduction of AHI by 50%, he's actually looking at AHI going down to below 5, and he's having very good results with that, but I only saw him in April, so it's still early days, and he needs to expand his studies. Manapati, obviously you're all familiar with that, looking at the oral cavity, something you guys do every day. It gives you the heads up, so if you see a Madanpati 4 in one of your patients, do the stop back. Just ask the question. I surveyed all the clinics in England and Wales in 2012, and actually it's quite interesting. About 33% are ENT and other. Respiratory only about 57%, but actually what doesn't reflect there's actually respiratory, a big overall slice, about 98% of all clinics have a respiratory physician in. So sometimes it's with ENT, sometimes it's by themselves. And there's Max-Fax and anaesthetics. I know Leicester was originated by anaesthetists. So there's no fixed way it must be. I mean, all of them work reasonably well together. As long as you get good outcomes, I don't think anybody cares. We did ask them, well, how many of you examined the upper airway? And about 77% felt they did. Half of them looked in the nose. They felt was a good thing to do. Most people looked, about 80%, in the oral cavity, which seems sensible. But only 20% actually nasendoscoped patients. And I'm an ENT surgeon, and I can tell you, I can't look into somebody's nasal cavity from the front and see through to their postnasal space. It's not possible. Okay? And some of the other slides I'll show you, which will be interesting. You have these interesting bun fights with your colleagues. It's like, in 25 years, I don't see why I should look in the airway. I think that's madness. I think that's a bad idea. Instead, it's a bad idea to write it down. Not missing anything. Maybe you're at the stage in your career where you just don't want to learn anything else because you must have missed something. I'm not that confident about my practice. Then we had excuses about, that's very costly. You don't want to be doing that. Or we'll do it if CPAP fails. Well, actually, if CPAP fails, you've got the trial of a unit, you've got a wasted mask, you've got another split night admission. You're looking at £1,500. It's painful? No, it's not. Not if it's done properly. You do it with KY jelly, no local anaesthetic, it's absolutely fine. But you visualize the airway. If you were a plumber, you'd look down the drains before you did anything to it. I'm saying if you don't look, you can't see. It costs £10 a patient. Allergic rhinitis, hugely engorged turbinates, that's a problem for you, and that's going to affect your airflow dynamics. This is evidence to show that allergic rhinitis patients do have trouble sleeping, and they feel unrefreshed in the morning. You treat them with topical nasal steroids and antihistamines, they tend to get better. If you put people on CPAP and you blow about 2 million litres of air up their nose at night, yes, the nose doesn't like it. Especially when you initiate. The first few weeks, what you find is that real stuffiness. You have to warn that your nose will feel like you've got a cold, but actually you don't have your cold. It's a reaction from the CPAP itself. So you give them topical nasal steroids, antihistamines, decongestants if you can, and they're not hypertensive. And then bent bent septum. That's going to deflect airflow significantly for you. Large nasal polyps, obviously you won't see that by anterior rhinoscopy. This is right at the back of the nose, but there's a certain sound to people who have nasal blockage from polyps. Other tumours, lesions, things like that, infections. You're not going to see this with anterior rhinoscopy. Large adenosine pads. Every now and again you get a postnasal space tumour, which is not good news, and you wouldn't see that unless you examine properly. Nasal surgery. If you just do nasal surgery alone, you've missed the point. It's a multi-level